My name is Olivia. I'm a third-year med student at the University of Iowa Carver College of Medicine. And today we're going to be doing a neurology topic, and that's going to be over stroke. I'm going to kind of breeze through this beginning part that we don't really do content with because I feel like, it's taken long enough. But this is going to follow kind of our usual outline of things. So if you're new here, welcome. We always start off with doing like an example case, which will include a physical exam and differential diagnosis. And then we'll kind of move into the assessment and plan and do the second half more on the pathology of disease. So this works really well if people are actively participating. I invite you to either use your like microphone if you want to unmute yourself, or just type in the chat if you're more comfortable that way. And then also hopefully everyone should have the link to the SOAP note that I posted. If not, then I can drop that back in the chat, or maybe somebody else, if they have it pulled up, can copy and paste the link into the chat. So that's something that you'll do kind of throughout the presentation. So this is what it looks like. We're going to skip the annotation today. I'm sorry, everyone. And we're going to just jump right into our case. So we have a 79-year-old male who is presenting to the ER with a chief complaint of sudden onset right-sided numbness. So just with only knowing that information, what are some questions that you guys might want to ask him? Matthew's saying to have him lift his arms and have him try to talk. That's definitely two things that in stroke, which is probably the most severe thing that we would want to rule out in somebody who's presenting with sudden onset numbness. And Madeline says smile. So yeah, those are all testing kind of like motor function that if it's not working on one side, then would be very concerning for stroke. Owen saying sticking out their tongue. Again, that's perfect. Physical activity. Yeah, have they been like physically active? Is this something that just like has ever happened to them before maybe and then resolved, or this is their first time experiencing that? If it's better or worse at times, yeah, that's definitely good information to ask about. So we'll move on then to some additional details. And we find that this was first noticed 35 minutes ago by his wife, who said that he was also slurring his speech during that time and had some facial drooping. Prior to this, he was outside fixing his tractor and then had come inside to eat lunch. And that's when his wife first noticed this. And then he was brought to the ER by his son, who lives nearby, as soon as they noticed what was wrong. So for some past medical history, this is all great information to put in the subjective part of your note. If we need to come back to this at all, then just let me know if I need to return so you can make sure you have this in your note, or we can always come back at the end of the presentation. But so past medical history is really important in evaluating for a stroke because that will tell us a lot about their risk factors. So for this particular patient, he has a history of hypertension, coronary artery disease, and hyperlipidemia. Those can sometimes go hand in hand, where you get plaques within your coronary vessels. And he also has type 2 diabetes. So the medications he takes kind of correlate to those chronic conditions and are pretty typical for this age group of people. So he's on a diuretic called hydrochlorothiazide, or HCTZ. It's a long word, so that's the abbreviation for it. And that's basically a heart medicine that helps prevent edema of the legs. He also takes metoprolol, which is a beta blocker, and that can be used to lower blood pressure and some other effects on the heart. Simvastatin. Does anybody know what the classification of a statin does? Any drug that ends in statin, they're all kind of from the same family. And what condition are they used to treat? If anybody knows this, I will be very impressed. Yeah, awesome. Looks like Josh and KH both said cholesterol, which is completely right. Yeah. So this is a lipid modifying medication. It's from, it's, I guess the mechanism isn't super relevant to this, but they're the first line to help lower cholesterol in people who have like dyslipidemia. And then metformin and insulin are both diabetes medications. And then he just takes a baby aspirin every day because he read that it's good for heart health. So like I said, pretty classic heart or medications for this age group. The other very important piece of his past medical history is that he had a STEMI 12 years ago, which can anybody tell me what a STEMI is in like colloquial terms? Like if you just heard on the street, like somebody had blank, a heart attack. Perfect. Yeah, Madeline hit it right on the head. And his status post a stent. So a stent is placed in people who are candidates during a heart attack to help provide revascularization to the affected part of the heart muscle to prevent any further damage. So knowing that he's had a couple of vascular events in his past and that he has sort of these other risk factors of having maybe some clogged up arteries, some high cholesterol and diabetes. So he definitely has this sort of not great metabolic picture and has already experienced some really bad consequence of that with having a heart attack. On top of this, he also has smoked 2 packs of cigarettes per day for 40 years. So that's an 80 pack year history where we multiply the number of packs smoked per day times the number of years. And that's very, very high. That's definitely going to put him at an increased risk for multiple like comorbidities and health conditions. And his occupation, he's a retired farmer, which would explain why he's out working on his tractor today. And for his family history, it's pretty non-contributory. So for a differential diagnosis of a neurologic condition, the easiest way that we break these up would be into acute onset versus chronic onset. Things that happen acutely can range from being like sudden onset, like in 1 second, something changes. Something like that would be a stroke, like you notice it right away. Trauma as well, that would be probably a little bit more obvious because you would know that the person had some sort of traumatic injury when they came in, but then that's a sudden onset type of etiology for that. Metabolic derangements and infections are a little bit longer, like they can take up to hours or days, but they would still classify as acute. So those are the easiest ways that we can help kind of differentiate those from things that are more chronic. Examples of this would be brain tumor, for example. That's going to be something that's slow growing and can take weeks or months to have the onset of symptoms. And it probably is also going to be progressive over that time. Same thing with neurodegenerative diseases like multiple sclerosis, for example. That's something that's going to be very progressive and slow moving. And then lastly, people who have substance deficiencies or vitamin deficiencies, for example, or toxicities with like metals, for example, like a lead toxicity or lead poisoning. These things are going to take a while to either accumulate or deplete, depending on if it's an excess or a deficiency. And those are going to be not presenting acutely like hours to days with their symptoms, but take a longer time. So again, like I said, this is just the easiest way to break it down. Think of things that can happen really fast as being the acute ones, which would be vascular or trauma, metabolic, and infection. The other stuff all kind of goes into the chronic category. So moving on to the objective portion for your note, we're going to start with our physical exam, and that will always begin with looking at their vitals. So we're looking at his blood pressure, and that's 156/92. Does anyone know if that is abnormal? And if it's abnormal, is it low or high? Yes, it is high. He is hypertensive right now, which makes sense because we know that he has hypertension. Some people have a more like well-controlled blood pressure, even if they have a hypertension diagnosis. So this can either be due to like the effect of what he's experiencing in his symptom presentation, or he might not be compliant with his medication. Those are just a couple ideas for why it might be high right now. His heart rate is 78, and that's within normal limits. His respiratory rate is 16, and his temperature is 36.8 C, and his oxygen saturation is 98%. So everything here is within normal limits, except his blood pressure is high. On exam, he just general looking at him, what do you see? What do you observe? He is a anxious appearing male, he's in the emergency room and he's, a little nervous about what's going on. And I think that's understandable. A lot of people, if they realize all of a sudden that they are having this really sudden onset change, would be anxious appearing. For cardiac exam, he has a regular rate and rhythm. He doesn't have any murmurs. For his lungs, they're both clear and equal breath sounds bilaterally. His abdominal exam is insignificant. He has a soft, non-tender, non-distended abdomen. And for his extremities, he doesn't have any cyanosis, no edema, no discoloration or trauma. And the reason I wanted to bring up the extremities is because depending on what his right-sided weakness and numbness was, like if, for example, it's just in his right arm, then sometimes you can get like a peripheral obstruction of the blood vessels, or like if it's just in one leg, it could be something like a blood clot. And so you would want to differentiate that from having it be something central in the CNS. So that's just something to consider, but all of this is looking so far pretty normal. Where it gets a little bit more interesting is in his neurologic exam. And the neurologic exam is composed of 7 different parts. And so the first one is mental status. So we're assessing if they're oriented, if they're alert and they know what's going on. The 3 things that we want them to be oriented to are person, place, and time. So you would ask, like, do you know what your name is? If they have a visitor with them, like his wife or his son, it sounds like his son brought him in. So do you know what his son's name is, or what the relationship is there? Does he know where he is? What kind of building is it? Is it a hospital? Is it a school? Is it a mall? Asking for the city and state that they're in can also be helpful. And then the time. So asking questions like what day of the week is it, or what year, or who's the president right now, could all be good questions to assess for their orientation. We also are noticing just by interviewing him that he has like a moderate aphasia. Does anybody know what aphasia means? Yeah, difficulty speaking, can't express themselves. Those are both perfect answers. We'll go through kind of the 2 different types of aphasia a little bit later, but we specifically noticed that he's having trouble naming things. So if you were to hold up like this and ask, what is this? He might not be able to say, this is a cell phone. If you ask to point to your finger or your hand or something, maybe he can say, oh, this is my hand here. But if you point to a knuckle or a ring, they're not able to make that distinction at like a smaller scale. So again, that's just something to note, that he has this moderate naming aphasia. Moving on to the cranial nerve exam, this could be a whole virtual rounds on its own. So I want to keep it really brief and just stick to having it be that he has this right-sided facial asymmetry and drooping. And the cranial nerves are, I'll talk a little bit more later when we go over brief neuroanatomy, but that can be used to assess their brainstem. For the motor exam, we see a 4 out of 5 strength of his right arm and 3 out of 5 strength of his right hand. So normal would be 5 out of 5 strength, where you're able to lift against gravity and lift against resistance. 4 out of 5 strength is usually that they have a little trouble with resistance. And 3 out of 5 strength is that they are able to kind of lift against gravity, but not much else besides that. For his sensory exam, we see a sort of global decrease in sensation. There's all these different types of sensation in the nervous system that include fine touch, pinprick sensation, temperature, vibration sense, all those different types of sensations. And we're seeing a decrease in all of them in the right side. The rest of his body, however, is intact. So he doesn't have any deficits in his legs, on the left side of his arm, anything like that. The fifth part of a neuro exam is reflexes. So classically, you'd think of like when you go to the doctor and they hit your knee with the reflex hammer and you kind of have that knee jerk response. That's one example of a deep tendon reflex. And we see that for his, I guess I didn't specify here, but on the right side, like his biceps reflex is slightly exaggerated. So that's hyperreflexic, and that could be benign, or it could be contributing or a finding of what he is presenting with. And then the last two, gait and coordination. Gait is assessing your ability to walk and have like good posture. And so his gait was normal and his coordination was also normal. That would be a movement like rapid alternating movements of the hand, doing like a finger to nose test to see if they're able to use kind of like their depth perception, and looking at a moving target and able to coordinate the movement of their arm. And so these were all normal on his exam. So the big things to take away here is this aphasia. He had a right-sided facial droop, and then he also had right-sided arm deficits in motor and sensory. So I like to put in these little question breaks because otherwise I'll just go on like at 10,000 miles an hour. And I want to make sure that we're going at a speed that is appropriate for you guys and that you feel like you have a chance to ask questions and process everything. So is there anything that I can answer at this time, or am I going too fast, too slow, too much detail? Any feedback? Pace is good. Okay, thank you, Justin. All right. So if there's any questions that come up, just feel free to stop me, put it in the chat, interject. I don't really have a preference how they're asked, but I do want you guys to make sure you have a chance to ask questions. Okay, so we're gonna start doing a workup after we've done his history and his physical exam. What kind of tests would you like to order to try to determine what is causing these symptoms for him? A head CT. Yes, I'm so happy that you guys said that, because that is actually the first test that we do for somebody who has symptoms that are concerning for a stroke, and specifically a non-contrast CT. The reason we do non-contrast is because to do the IV contrast and to have it kind of get into the right phase of the circulation can take a lot of time, and it's not really that helpful in determining like the differences in like a stroke. We're able to see strokes on a CT without the contrast, and we want to really just work them up as quickly as possible and do their evaluation without wasting time, because as you'll learn a little bit later, every second counts. So this is his CT scan. Before I go to the like interpretation of it, does anybody have any comments about what they see here? Anything that looks abnormal? Things that look normal? What are your initial thoughts? And for orientation, I was going to talk about this even though I marked it, but so the way that we look at a CT is, so imagine that the patient is laying in front of you on their back and their feet are pointing out towards you. So you're looking kind of like down at them. And this is a cut through their head transversely. So this is probably at maybe a little bit higher than the level of the ear. And the contrast here, so the bone shows up really bright white. That's the skull. And then the air is completely black around it. And then the things that are black on the scan are like water density. So these, hopefully you can see my cursor, but these sort of like, I don't know how to, like boomerang looking things. These are the ventricles and they contain cerebrospinal fluid. So that's why they look like they have a water density. Those are supposed to be there. And somebody is saying that the right side looks different from the left. Yes, that's accurate. The sides do look asymmetrical. So that's a great observation to make in the brain. It's nice because we're able to compare between the two sides. And that's my first approach to reading a CT, is looking at what looks different between the right side and the left. And here we're actually seeing that the left side is the abnormal one. And I'll show you guys why. So it's very subtle here. And I wanted to find a better picture, but I feel like the other ones that I found were either like too complicated or had like labels on them that I didn't like. But here we're seeing that on the left side, there's this sort of decreased density. So it looks slightly darker than the surrounding tissue where it's kind of that like lighter shade of gray. And if you compare to the right side, there's also like less definition of the gyri or the folds of the brain. So here, like we can see there's a really nice like folds with some cerebrospinal fluid that's like in between it. And this is all sort of just like muddled together. And that's because there is some edema of the brain or swelling of the brain tissue because of a local inflammatory response. So this left side is actually the abnormal side and the right side is normal. Again, it's a very subtle thing. If I were given this as a pre-med, I would not probably even know what a normal is supposed to look like. And so props to you guys for picking up on the asymmetry. That's definitely the first thing that you can look at when you're first learning to read CTs. Are the ventricles bigger than normal, or is that how they usually look? That's an excellent question. So the ventricles will vary in size depending on the level of which you're slicing. And I should also say that in reading a CT, it's not just a single cut of the image. You can scroll through from the very top of the head all the way down to the neck and be able to see the different slices that they take. And at this level, I would say the ventricles are probably normal, but I would have to see compared to the ones that are above and below it, if they're truly like in 3D normal. This is just taken at a level that the sort of posterior ones here especially are looking maybe a little bit big and maybe a little bit asymmetrical as well. And I think that it's hard to tell just with having this one image if it's artifact or if it's real. So Hannah, that was an excellent question. And the answer is we can't really tell without having the rest of the scan. Okay, so the CT, the physical exam, knowing his history and everything, that's all going to help us formulate our assessment. And I normally don't like to put these big blocks of text on the slides, but I think that the assessment really pulls together all of his story and helps us to make a final diagnosis. So we have a 79-year-old male with a history of hypertension, hyperlipidemia, type 2 diabetes, and coronary artery disease. And he also has this 40-pack year smoking history. I think I made a mistake. This is supposed to say 80-pack year because we said he did 2 packs a day. But regardless, he's got a ton of smoking history. And he's presenting with acute onset, right-sided numbness and weakness. And then on our exam, it demonstrated focal deficits of the right upper extremity, slurred speech, and mild aphasia. So the non-contrast CT revealed a left-sided area of ischemia in the left temporal lobe. And we'll go through the anatomy here in a little bit. So this is kind of jumping ahead. But the final diagnosis here is going to be an ischemic stroke of the left middle cerebral artery. So again, that's a lot of information. We really are just trying to pull like the highlights from all of our workup so far to justify what our diagnosis is going to be. So with his diagnosis, it's going to be a stroke of the left MCA or the middle cerebral artery. Please don't worry about the specifics of the artery. You cannot see it on the CT, so don't try to look back and see exactly where the artery is clogged. That's not how this exactly works. And you wouldn't know that right now with the level of understanding of neuroanatomy that most people have before med school. So just know that this is an ischemic stroke is the takeaway. And the plan for him is going to be to do stat IV thrombolytics and antiplatelet therapy. Can anyone guess what thrombolytics are? Like what's the mechanism that they have or what's the goal of giving somebody a thrombolytic? Clotting, yeah. So it's actually Removing clots. Yeah. So Sammy got it, and Alejandra was very close. So it's basically a drug that's a clot busting drug. Thrombo, the Latin root meaning like clot or blood clot, and lytic meaning breaking it up or dissolving it. So these are IV drugs that we give and are basically like a super aggressive blood thinner that will help to break up any blood clots. And then he's also going to get antiplatelet therapy, which is a less extreme version of that, but it's going to prevent further clots from forming. And then he's also going to get admitted to neurology for further workup and more observation for his symptoms. Okay, so we went through the imaging and the assessment and plan. Do you guys have any questions at this point before we get started on the pathology? I think it'll also make a little bit more sense when we go through the pathology because I'll touch on a little bit of the neuroanatomy and correlating his symptoms with what we saw on the scan. So if we're all good, I'm going to just keep going and hopefully it'll clear up any confusion that you might have at this time. Okay, so a couple things to keep in mind for neuroanatomy. Some people know this and some people don't. I don't think I knew this before med school, but the left side of the brain actually controls the right side of the body and vice versa. So if you remember, he was experiencing symptoms on his right side, but on the CT, we saw that the affected area was on the left. So it's just something to keep in mind that a lesion on one side of the brain will produce symptoms on the opposite side of the body. Just general principles. This is kind of true for like all anatomy, but especially in the brain, each area is supplied oxygen, nutrients, and stuff by blood that comes from a specific artery. So a stroke is going to produce symptoms based on the area that's affected in the territory of the artery that's affected. And then not everything in the brain is symmetrical. It is in terms of the like actual structures that we saw on the CT, but functionally some things are only on one side or only unilateral. So here's the thing with the aphasia that we were talking about, remember? So his lesion was on the left side of the brain, and in the temporal lobe, which is where the language center is, you have the Broca's area and the Wernicke's aphasia. Some people, I think, may have taken like AP Psych or maybe like a basic neuroscience class, so you might know about the Broca's and Wernicke's areas. But these are basically the two different areas of the brain that contribute to understanding and expression of language. Broca's with the speech side of things, so expressive, and Wernicke's meaning understanding of language that's being spoken to you. And that's only on the left side of the brain. So even though you have two temporal lobes, one on the left and one on the right, only a left-sided temporal lobe lesion is going to produce aphasia, if that makes sense. And going along with that, symptoms of a stroke are highly dependent on the area of the brain affected. So like we just said, the left temporal lobe would affect the language center and produce aphasia. The occipital lobe, which is where you do a lot of your visual processing, that would produce like visual defects. The cerebellum, which is kind of at the base of the brain, and it does like coordination and balance, that would give you deficits in those functions of coordination and balance. And then the brainstem, like I said, with the cranial nerves, you would get more of the cranial nerve deficits. So the point, I don't want you guys to get too confused or hung up about the specific areas right now. Just these like general principles. And we'll go a little bit into the neuroanatomy, I think on the next slide. Any questions right now? I know this is a lot of details and hopefully either maybe you've had some exposure to these terms before, and if not, that please feel free to ask for clarification, because I guarantee if you are wondering about something, then somebody else is also wondering about something. Okay, so here's very, very basic breakdown of the different lobes of the brain. So First, we have the frontal lobe, and that's what it sounds like. It's kind of in the front of your head by your forehead. And this is a place where a lot of your executive functioning happens. So, like making decisions, your judgment, and your problem solving, that all kind of happens in your frontal lobe. And then the very back part of the frontal lobe, kind of right by the crown of your head, is where the primary motor cortex lies. So just keep that in mind. The parietal lobe is then kind of like the back, the top back of your head, like where the crown of your head is. And that's your primary somatosensory processing area. So again, like the motor cortex and the somatosensory cortex kind of like sandwich each other a little bit. And that's why with his stroke, which is outlined here in red, we got both the motor deficits and the sensory deficits. So that's kind of interesting that the territory of the vessel that was obscured supplied both of these areas. And so that's why we saw both deficits on his exam. It's kind of cool. Again, we talked a little bit about the temporal lobe. Another function that it has besides language is hearing processing and memory. And those again lie in kind of different areas of the temporal lobe. And this circle here is not exactly the territory of the artery that he had affected. So for like imagination purposes, maybe his hearing processing was a little bit below that and his memory is more like medial or like behind it. So just, yeah, again, imagination kind of a little bit with this simple diagram, but the overlap of the three different centers is all due to the same artery being occluded, if that kind of makes sense. And then not so much clinically relevant for this case, but just for your own knowledge that the occipital lobe we talked about does visual processing. That's in the very, very back of your head, like almost kind of by your neck. And then the cerebellum sits kind of right underneath the occipital lobe and on the brainstem, it kind of like sits on top of the brainstem like a little backpack. And we said that does balance and coordination. And then the brainstem has a lot of your autonomics and your vitals function. So like your heart rate, your blood pressure, your, I don't know, response to those types of things. And then of course, like we said, the cranial nerve nuclei live there. So you can also get deficits there. I know this might be a lot. If you have a background in this, it might be super easy. So I want to just make sure that everyone is able to keep up with and understand this. So thank you for bearing with me if you have seen this before, and if not, I hope that you feel comfortable asking questions for clarification if you need that. Because like I said, when I was a pre-med, I didn't really have any exposure to this stuff. So I'm really impressed if you guys are able to keep up with this. And then lastly, please do not like read too much into this at all with the labels and the angiogram that's on the side. But this is just demonstrating the blood supply to the brain. It's called the Circle of Willis. It's a very, very cool structure that is just, I think, very beautiful anatomically. You get two different inputs to the Circle of Willis. One comes from the carotid artery. So you have your heart and your aorta. The carotid stems off of the aorta and it travels up your neck and kind of through your skull and then goes through your skull and into the brain, kind of more anteriorly. And then the second origin is the vertebrobasilar circulation. So that's, again, branching off of the aorta, but it goes around and feeds the spine. And then those arteries, there's two of them, they kind of converge and form the basilar artery that goes up here. So you have two different inputs of blood, and they will form what's called an anastomosis of different vessels that form this really beautiful circle and have all of these different branches coming off of it. And the point of that is to ensure that the very vital portions of the brain will always have a like backup blood flow. Like if you lose one part of your circulation, then the parts that come up from it are also providing collateral blood flow, if that makes sense. It's kind of like a fail-safe for the brain because it is pretty much the most important organ in the body. Some might argue with me on that, but You can't get a brain transplant, you can't live without a brain. And so you want to make sure that you are supplying and protecting those neurons as best that you can. And so the evolution of our human neuroanatomy did a great job in designing this circle of Willis. Again, please don't look at all the different labels here. I just want you guys to be able to see the representation of a textbook here. And then that's what it looks like in a real person. So that's pretty cool. Okay, so that was our little intro to neuroanatomy. I'm just going to check the time quick. It's been about a half an hour, so we're right on schedule. Again, if anyone has to leave, I will not be offended. This will be posted on our YouTube, and you're welcome to do the certificate and quiz like at a different time, because I know we probably have some people on the East Coast and it's getting late for you. So if you do have to leave, then feel free to do that, but we're just going to keep going along here. So the two different types of stroke, I mentioned one earlier. So our patient had what's called an ischemic stroke. There's, like I said, there's the two types. There's ischemic and hemorrhagic, but both of them are due to a loss of blood flow of the blood vessel in the brain, resulting in tissue death within that territory of the vessel. So a vessel might feed different like functional centers that all have the same like territory. And that's why we get those specific symptoms. So starting with ischemic stroke, this is the majority of strokes that you will see. It's about 80% of the strokes are ischemic, and that's due to an obstruction of blood flow due to things like an embolism, a clot, a plaque, etc. So it's almost like a brain attack in the sense that it's similar to a heart attack. It's just in a different part of the body. A heart attack is like a clog in the artery that supplies the myocardium. This is a clog in the artery that supplies the brain. And as opposed to hemorrhagic stroke, contrast that with where you actually get a rupture of the vessel and you are leaking blood into the brain tissue, which maybe initially sounds like it's not bad because there's still blood flow there. But one, it can cause compression of the brain, and there's not that much space left in the skull, accounting for all the tissues that are there. And so it's can be really bad if you're adding too much volume inside of it and causing like all of that swelling and pressure to build up. And then also if you disrupt the blood flow and it's leaking out into the surrounding tissue, then everything downstream of that is also not receiving blood flow. So both of them are bad. The hemorrhagic classification is less common. It's only about 20% of strokes that are hemorrhagic. And they can be due to multiple different things. So like I said, with the ischemic stroke, it's kind of the inverse of that. So people who have like blood thinners, or if they have aneurysms that tend to like blow up, or if they have really, really extreme uncontrolled hypertension, we're talking like into the 200s systolic, then you can have a hypertensive crisis that results in a stroke because your blood vessel just literally cannot contain the blood pressure that's inside of it and it just blows. So yeah, not good stuff. Our patient had the ischemic stroke. And I also wanted to add that there's a cousin of ischemic stroke called a transient ischemic attack, or a TIA. And that's essentially where you get symptoms of an ischemic stroke that last less than an hour and there's no lasting impact of them. So they just resolve spontaneously. And you also can't see any evidence of it on imaging. So that's kind of like a lucky chance that the blockage of the artery just resolved on its own, whether it was broken up by the body's natural defenses or it just, I don't know, like traveled somewhere else. It's definitely not good, and it can indicate that you have a risk for future ischemic stroke. But the point of this being that you can have stroke symptoms that go away on their own, and that doesn't necessarily count as a stroke, if that makes sense. Okay, so we have the two different types of stroke here. That was kind of the highlight of these slides. And I wanted to show you guys on imaging because we used an actual CT for our patient. This is a little bit of a better picture where you can see all of this dark space. On the, what is this? It's backwards. So if this is my right, that would be the left side of the patient, where you don't see the like outline of the tissues. There's a lot of obscuring of the gyri. It just is not looking good. That's a really, really bad ischemic stroke. Contrast that with a hemorrhagic stroke, where you get a lot of enhancement of the area where there's a bleed. And this is kind of showing that thing where there's two different slices that you can kind of scroll up or down. And so this is the same patient, but just a little bit more inferior from what the first image is showing. And all of this like really white enhancing stuff is just accumulation of blood. And again, you're seeing compression of the surrounding tissues because you only have so much room in your brain to add mass to. So this ventricle is pretty much toast. All of the surrounding stuff, you get this kind of midline shift that is, yeah, not a good prognosis there. So that's kind of the difference between them. You'd get this really bright white stuff for the hemorrhagic and this dark side for the ischemic. Okay, so a little bit on the epidemiology and the risk factors for stroke. And this goes for, I guess, primarily ischemic stroke. But I think for these, these non-modifiable risk factors, it's the same for both. But age is the #1 risk factor for stroke. Old people just have strokes much, much, much more commonly than young people. And in fact, if a young person has a stroke, it's usually due to an underlying pathology, like a clotting disorder, for example. There's also a difference in sex. So at younger ages, women are more likely to have strokes than men because they have estrogen, which is a like hypercoagulable hormone. But then once you get older, then men have a higher risk than women. And then also race and ethnicity. So this isn't necessarily due to inherent physiological differences, but due to systemic disparities in diagnosis of comorbidities, treatment, access to care, things like that. And so people of Black, Hispanic, and Native background will have higher rates and worse outcomes for stroke. Those are all the non-modifiable ones that you can't do anything about. It's just like everyone's going to get old, or you're born a certain sex or with a certain race. There are several modifiable risk factors that you can either take medication for or make behavioral or lifestyle changes. So the ones that we talked about, and our patient had a lot of these, was the dyslipidemia, having high cholesterol, diabetes, especially type 2 diabetes, and high blood pressure, and then heart disease just in general. One thing that I didn't really mention yet, but atrial fibrillation, or AFib, is another really big risk factor for stroke because it makes you way more prone to having blood clots that are like literally come from your heart and are pumped out through your aorta and into all of your arteries. And then lastly, smoking. Smoking's bad for you. I think everybody knows this. Sorry. Smoking's bad for you, and it's a risk factor for almost every disease, I think. Okay, so why are men more likely to be susceptible to having a stroke in older ages? That's a really great question. I don't know if this is actually evidence-based, but if I had to guess, it's that men are more likely to have those comorbidities like heart disease and high cholesterol and things like that as they age compared to women. And so they would be more likely by virtue of those comorbidities. But again, that's just my guess. I don't know if that's actually how it works, but that is a great question. What other questions do you guys have about the neuroanatomy at all, or all of that stuff that we went through? Hopefully that was clear. Okay, we'll just keep going then. We're almost there. So for the pathology, and this part's actually very brief, I think, because we just did pretty much all the heavy lifting with the background and stuff, but we talked about these lifestyle factors like smoking, poor diet, being sedentary, And that all contributes to having large artery atherosclerosis. And that's the medical term for like plaques that build up in your vessels. So a big one that we see is the carotid artery, like the one that is running through your neck and supplies that anterior circulation to the circle of Willis. And if that builds up a lot of plaques, then it can throw like actual emboli, or like the clot or the plaques can like break off and travel downstream into the brain. The atherosclerosis also just in general can accumulate anywhere. So it can be in large vessels. It can also be in the actual arteries of the brain themselves. Sometimes on people with really junky arteries, you can actually see on their CT like enhancements where the plaques are, because there's a lot of calcium in those. So it looks like it's bone, which is kind of crazy. So you get this narrowing of vessels, and high blood pressure can both contribute to the rupture of those plaques, and it travels downstream to the artery that it just eventually will get lodged in. For our patient, it's specifically the MCA, or the middle cerebral artery. Again, please don't worry about the actual location of that artery. And then once you have that artery blocked off, then it's not able to supply the rest of the downstream capillaries and everything with oxygen-rich blood. And so you lose the support that goes to those neurons and the glial cells to do their functions, like allowing you to have motor function, sensory function, and have like good healthy metabolism of the brain. So they will just die, and you'll have necrosis of that area of the brain eventually. And long term, you'll have inflammation and scarring, but that's not like the short term pathology of it. So on correlation to our physical exam, we saw that because the MCA was blocked, we saw that his primary motor cortex resulted in right-sided upper extremity weakness and also facial droop. The primary sensory cortex is responsible for the numbness and the tingling, and then his left temporal lobe produced the aphasia. So again, that's all kind of in the same territory as this giant artery called the MCA that provides blood to all of those structures. We already went through kind of the initial, like super fast, you got to get that CT, that non-contrast CT as soon as possible. That is the gold standard in diagnosing stroke. Some other acute workup that we would do while he's still in the emergency room would be a basic metabolic panel to look at his electrolytes and his glucose. Because if you remember, another one of those acute causes of neurologic deficits can be metabolic abnormalities. And so we would want to rule out something like having like a really weird sodium level, for example, or he's like super hypoglycemic and his brain isn't getting enough sugar. It's less likely based on the fact that these are all only on one side. That suggests something more structurally wrong, but we would still do these labs as part of a standard workup. And then I didn't go into this, but the NIH has a stroke scale with a very, very specific and systematic evaluation of physical exam, neurologic exam type things to try to be able to localize where in the brain is affected before you even do the imaging. So it's kind of cool how you can pinpoint pretty much exactly where it is depending on what their symptoms are. And then while, like we said, he's admitted to the hospital for observation and for further workup. So he's on the neurology unit, he's gotten his thrombolytics, and so his actual acute stroke has been treated, but we still want to figure out why he had the stroke and prevent it from happening again. So we would want to do additional screening labs for things like lipids, a hemoglobin A1C to see how his diabetes is being controlled. If maybe he's not taking his medicine and he has really out of control diabetes, we'd want to know that now. And then his coagulation profile, is he hypercoagulable for some reason? Josh was wondering, would knowing the location change the treatment? And the answer is no, it doesn't. It is just sort of, well, I should backtrack a little bit. So knowing the type of stroke would change the treatment. So if it's hemorrhagic or if it's ischemic, you would do different treatments for those. And then depending on the location, the patient might be eligible for an interventional procedure called a mechanical thrombectomy. I think I have this on the next slide. Let me see. Or two more slides. So we'll hit that eventually, but there are some surgical interventions that you can do depending on if it's like a large enough vessel that you can go in and actually physically remove the blockage, which is really amazing. And I'll get to that later. So I guess it would maybe make them more eligible for that type of treatment, but in terms of their medication management, it would be the same given that it's either an ischemic or a hemorrhagic stroke. So does that answer your question? Okay, perfect. And then other procedures that we would do would be an echo and an EKG to evaluate the heart and rule out AFib. Like I said earlier, that can be a big risk factor because you are more high risk of throwing blood clots out of your heart. So we want to make sure that this person doesn't have AFib that's just undiagnosed. We would also do a carotid artery duplex ultrasound to see how much blood flow is actually going through the carotids. If they're very atherosclerotic and like just tons of plaque, then we might have to go in and do an additional procedure to help open those up a little bit more. But you can't know without doing the ultrasound. So it's a very non-invasive and inexpensive way to evaluate for that potential comorbidity. And then also, this isn't super routinely done, but some people do an MRI to either for prognostication or to better evaluate the area that's affected. And that's highly dependent on the location that you're in. Some hospitals, especially like rural or underserved areas, don't even have MRI machines. And so it's definitely not like a required part of this workup, but it is something I think that I've seen done in some cases. This is just some more like facts, I guess, so you guys know just like how urgent it is to do that initial workup as fast as possible. So the American Stroke Association recommends a door to needle time of 60 minutes or less. So by the time they come through the ED, you have to do your exam, get your history, do the non-con CT, decide if they have a stroke, and then get them the medication, the thrombolytic, if they need it in less than an hour. And then we talked also about this thrombectomy option for people who have in certain areas of the brain, if they're eligible for a surgical procedure, that this treatment would be within 90 minutes. And the reason for that is because for every minute that a stroke goes untreated, you lose 1.9 million neurons, which is like mind blowing to me. And if you remember, I don't know if you guys know this at this point in your education, but neurons do not grow back. You do have like neuroplasticity where your brain can rewire and make new connections, but once your neurons die, they do not regenerate. So time is brain. You'll hear this multiple times from multiple people. And the goal is to just do a, thorough and complete workup, but to do it as efficiently as possible. And I wanted to touch on these other treatments, the difference between hemorrhagic and ischemic. So Josh was a little like one step ahead of me. So both of them, when they come in, you want to do an initial survey of their vitals, secure their airway, their breathing, and their circulation if it's not. So if they're like basically comatose when they come in, then you would want to intubate them and make sure that their airway is secured. That would be the first step, regardless of what type of stroke you have. Also, you can give them supplementary oxygen. If their blood is well oxygenated, then that will help keep their brain oxygenated and help hopefully like delay any brain damage that could happen from this. And then some people, depending on where they have the stroke, for example, our patient had some facial drooping and some slurred speech. So we didn't, I guess I didn't touch on if he had like any swallowing symptoms, but that can certainly be a thing that happens in patients with stroke, is that they have impairment of the muscles that allow coordinated swallowing. And so we might have to help work with them to find ways to relearn how to eat and drink and things like that. And then there's just general rehabilitation. So looking very long term into their recovery from the stroke, how are they going to learn how to adapt to these changes that are permanent for them? Especially with old people, they don't have as much neuroplasticity. And so you can make some improvements, but unfortunately, a lot of the damage that happens during a stroke is something that you will kind of have to just live with. And so there's really awesome rehabilitation teams and specialists to help with this population of patients long term. But then going back a little bit to the difference between the treatment for ischemic and hemorrhagic. So they have opposite pathologies basically. So ischemic being you have this blockage. So we want to unblock it if we can. And while it's still blocked, to keep as much blood flow to the brain as possible. So we give them permissive hypertension, which means in our patient, his blood pressure was like in the 150s, and we would allow that to stay high rather than try to bring it down. Because if your brain is not receiving as much blood, then that is again going to risk having further damage than is already being done. So we're allowing these ischemic patients to actually have high blood pressure during this time of being like worked up for a stroke. Again, the treatments for this would be thrombolytics. We talked about those already. And then the mechanical thrombectomy, which is the surgical procedure. And it's almost like doing a cardiac cath, but where you go in endovascularly through like a different part of the body, like in the groin, and you can actually remove the clot in the brain that way. So it's a very, very cool field of medicine to me. And then, of course, long-term, we would want to keep them on an aspirin or an antiplatelet drug to prevent any further potential clots. For hemorrhagic, it's going to be kind of the complete opposite. So we want to stop the bleeding in the brain. If you're just leaking blood out of this vessel, it's just going to continue to produce that mass effect and have even more detrimental causes. So we want to keep their blood pressure low, and we would give them like a fast acting antihypertensive such as labetalol, which is another beta blocker, to try to keep that under control. We're also going to elevate the head of their hospital bed up higher, so you get more, I don't know, like it's harder to work against gravity essentially in this, wait, like that's how physics works, I guess. I don't know, I wasn't good at physics. And surgical options as well for this, depending on how severe the area of bleeding is, you can do a decompressive craniotomy to help open up some additional space and create that room for swelling and for the displacement of tissue so that you don't have as much pressure building up. And then you can also evacuate the hematoma that's formed depending on the location of it. So that will help, again, relieve some of that pressure. But the big takeaways here is they kind of have different treatments for long-term treatment of this like hemorrhagic stroke. If they were previously on a blood thinner for a different reason, then you would definitely want to consider that when making like adjustments to their dosing, making sure that they're very closely monitored, that they're not too anticoagulated and are more prone to these types of bleeds. So yeah, those are some considerations there. And I think, can you have a mechanical thrombectomy if you've also started thrombolytics before? Now that is a very, very good question that I do not know the answer to. You're thinking exactly the right way. And that's probably like a clinical practice guideline that's somewhere. And it's definitely probably more at like the resident level of understanding like the treatment progressions. I would say that if they, so the turnaround or the window for this is like either 60 minutes for the thrombolytics or 90 minutes for the mechanical thrombectomy. Hopefully that was a bit like the decision was made intentionally before you start one treatment and not just do empiric treatment for this. But that's a really good question. I don't know the answer to that, but that's like the right way to think about it for sure. Because you don't want to have additional bleeding risk, right? So you don't want to give them like these super intense blood thinners to try to break up their clot and then go in and do a surgical procedure where you might induce more bleeding is the hypothetical here. But I don't know like what the evidence shows on that. That's a great question. I always like to give these little updates on our patients just for closure because you don't always get that in medical school. So our patient stayed in the hospital for 4 days and he was diagnosed with AFib after doing that EKG and the echo. So he goes on warfarin, which is a blood thinner, to prevent future strokes. He is discharged to a short-term skilled nursing facility to do some of that rehab because like his right hand, you know, is now going to have less strength and less sensation. So learning how to do things like brushing your teeth and getting dressed and cooking and cleaning and all those sorts of things takes additional time to learn how to do and to get like accommodations, or no, that's not the right word, but to basically like have assistance and relearning how to do those things. And then we also just in general for health maintenance are able to convince him to start doing a walking program to get some more exercise and to not be as sedentary, and then prescribe a nicotine replacement patch to help him quit smoking. So hopefully that goes well for him. These are my sources in case you guys wanted to check these out. This will be posted on our YouTube. And now is the time for you to start working on that quiz and the SOAP note if you haven't filled that in already. So 10 questions, and if you need to go back and use this PowerPoint at all, it should be in the Google folder with the resources. And if not, like I said, it will be posted on YouTube in the next couple of days. So you can use that as a resource. Is there anything that you guys want me to go back to right now if you didn't have a chance to put it in your note, or questions or things that seem still unclear? Thank you, Sammy. I was really stressed at the beginning with our technical difficulties, so I'm glad that it ended up going well and that people enjoyed it. Yeah, that was like my worst nightmare. So thank you guys for hanging in there with me and taking the extra half an hour. Is there anything else? Yeah, feel free now. The presentation is over, so feel free to take off and have a great night. And also, I really, really appreciate the feedback that you put in the Google form at the end of the quiz. That's literally how I pick what presentations to do. I think maybe like the last 3 or 4 of them have been not even in the field that I really even like that much. Neuro for me is actually really hard. So this was a step out of my comfort zone. But I had multiple people request a neurology topic. So if there's anything that you want to see that we haven't done yet, please put it in the feedback form. If there's any way that we can make this better for you guys, we really, really love to hear that. And it's helps me pick topics for the future sessions as well. So yeah, again, thank you guys so much for joining. You're absolutely free to go whenever you're ready. I usually wait until we kind of get a nice trickle of people that are going away before I end the meeting to give you guys a chance to ask any other questions that aren't related to even neurology maybe, and just more about medicine or med school or applying to med school or preparing to become a good candidate for medical school, anything like that. I try to give a little extra time at the end, and if not, then I just wait for people to leave to know that there's no more questions. So I'll hang around for a little bit until people start to head out, but it was great to be here with you all tonight, and I hope everyone has a very pleasant evening.